All right, welcome everyone. My name is Gal Tabachnik. I'm a program manager here at the Curry TB Center in San Francisco. Welcome to our webinar from TSTin3D to TSTin4D, Enhancing Tuberculosis Preventive Treatment Decisions with Risk-Benefit Analyses. And now I will go ahead and pass it over to Dr. Lisa Chen to get us started.
Hey, welcome everyone. Good morning, good afternoon to you all. I'm really pleased today to welcome a fabulous speaker. Many of you know him well, Dick Menzies. He's a professor of medicine, epi and biostats at McGill. He's the director of the McGill International TB Center, which is also a WHO collaborating center in TB research. Thanks to Dick Menzies and his team, we all now reach for 4R often, and we're very thankful for the research he did, bringing that to all of us, as well as his team's work on individual patient data meta-analyses, really the backbone for, I'd want to say, WHO global guidelines, as well as US and Canadian guidelines in TB. So we really thank the brain power coming out of McGill. So with that, Dick, thanks so much for joining us. Your tool has been wonderful, and we're all waiting to hear your update. So I'll hand it over to you. Thanks, Dick.
Great. Thanks, Lisa. Thanks, everybody, for inviting me. I'm going to switch to presentation mode. So it's kind of two parts to this talk, maybe three. A little bit mathematics, if you will, or the analyses behind the new tool, then a little bit on the new tool, and then I wanted to stray onto my favorite topic, which is new treatment and why we need all these risk-benefit analyses anyway. So when can we stop is all about, really, when you think about it, why do we need risk-benefit analyses? It's probably because the treatment is so risky. Okay, so disclosures. So I have a few grants. I don't really have any serious conflict of interest in terms of owning stocks or anything like that. And I'll talk a little bit about high-dose rifapentine, and levo for TPT. Okay, so the background. So the TSTin3D. So this was actually developed and posted in 2011. So it's really quite a long time ago now. Overdue. It estimated the risk of progressing to TB disease based upon a positive TB infection test, and basically was the TST. It considered three dimensions, so the size of the TST, the positive predictive value of the test, and epidemiologic and clinical risk factors. We really didn't consider mortality or disability after TB disease. We considered TPT adverse events, but didn't really talk too much about the benefits. And in fact, for TPT, we only talked about 9 months of INH. Didn't have 4R or 3HP or any of those. Again, as a reminder, this was produced or posted in 2011. So the older version, for those of you who've seen it, looks a bit like this. You get a, whatever, I'm not going to dwell on this too much. I'm going to actually show a little bit the new one. So the new calculator, so given that, of course, everything has to look better and fancier, we went with TSTin4D. So the first dimension is risk groups, second dimension is treatment, third is age, and the fourth is TB infection test result. I'll talk about these in order. So first of all, the methods, how did we calculate? So we, which is really my IGRA Bastos, spent about a year doing this. So a Markov model with probabilistic sensitivity analysis. The time horizon was 20 years. We looked at 4 treatments compared to none. So 9H, 3HP, 4R, and 3HR. Again, those were selected in large part because they're pretty broadly recommended, certainly US and Canada, but also by WHO. And there's quite a lot of literature that tells us about completion rates, adverse event rates, etc. So for example, 1 HP is not in the calculator because, again, we just don't have enough information yet. For age groups, you'll note still not kids, but adults, parsed into 4 groups. Input parameters. So there was a very extensive literature review and done again, led by IGRA. We drew on systematic reviews, but in particular, we were looking at the absolute risk of TB, not relative risk. So studies that looked at how many people, what was the actual incidence. And then we estimated QALYs, quality adjusted life years, risk of developing TB disease, disability, dying from TB, and then the benefits of TPT as well as the adverse events. So the risk groups, as I said, there's 20. I've highlighted 5 that I'm going to show you, which have, as you can imagine, a range of risk, ranging from general population healthy, recent immigrants, close contacts, all the way to people with HIV, persons with HIV on effective ART or receiving TNF-alpha. So again, the calculator has all 20. I'm just going to show you some as an example. So the first dimension, again, this is the effective risk group. So to show you risk, I've just kind of picked one age group and one test result. And so we have death, disability, and again, we've accounted for disability now in this new calculator. Disability is something that has been very much a kind of, people have recognized it over the last decade more and more, and realized that it's a pretty common outcome actually. So it's kind of all the more reason to prevent TB. It's not just you're preventing death, but you're preventing long-term disability. But again, the most important point here is the range in risks. So on the right are the bars related to just TB disease incidence. And again, you see the general population. So healthy young person, normal X-ray, no risk factors, maybe a student who has an IGRA or a TST. Their risk is low. Even recent immigrants are fairly low. You see, and then it goes up quite rapidly. A recent contact, a close contact, or a person with HIV, or a person receiving TNF-alpha inhibitors, sort of tops the list at 10 to 15%. Okay. So now combine the first and second dimensions. So same person, but now with treatment. And here we modeled different treatments. So 4R is blue, 3HP is green, 9H, and so on. And the reason that, and the black is no TPT, the reason why none of these go to 0, if you will, is because, of course, not everybody completes treatment, sometimes because of adverse events, but much more commonly just patient decision. They stop treatment early. And so using published estimates of completion and adverse events, you see 4R and 3HP look the best, but still it's not perfect. So what about adherence? As we developed the risk calculator, we realized that the estimates we were producing, which, although realistic, still don't answer the question that patients asked. So when I'm sitting in the office and wondering and speaking to somebody about should they take 4R or whatever, they always ask me, will it work if I take it? They don't ask me, will it work if I don't take it? Even they kind of know that. So in fact, the calculator has kind of a feature that you can, if you want to answer that question, not just the overall average accounting for likely non-adherence, then you can click on that and you'll get a risk, a reduction in risk with 4R or 3HP or whatever. And what you see is that 9H, for example, has the greatest difference because, of course, 9H has the lowest completion. So the light gray are, if I take it, what's the risk of developing TB disease with 4R compared to no TPT? And so you see that non-adherence is, of course, one of the big reasons why TPT doesn't work. Okay, the third dimension is age. So here it's interesting because I had always assumed that there wasn't that much point in giving TPT to older people, which admittedly the threshold for considering people old has advanced as I do. But someone over 65, you're kind of like, should I give them TPT? And so on. So what was interesting is that first of all, close contacts and many of these groups, as you know, the risk of disease is most in the first few years after the contact or after immigration or whatever. So in fact, most of the benefit, therefore, is indeed in the next few years. So, this notion that at least I had had in my head that, given the life expectancy, if you will, at 65, you're probably not going to get as much benefit. Turns out to be completely wrong. It's actually over 65 get a lot of benefit, and they get the most benefit. Why? Because TB is also a bad disease if you're over 65, with more mortality and more disability and so on. So in fact, preventive therapy actually is important in people who are over 65, at least if you have, an important risk factor. And that's what this slide is showing. What about the type of test? Okay, so this is a point that I kind of hammer away at locally. And since you invited me to give a webinar, I'll hammer away at to all of you. There is this notion that IGRA is like this huge advance. Oh my God, it's like the best thing since sliced bread. But really, when you look at it, in all the studies that are done, yes, people that are QFT positive compared to TST positive, the incidence of disease is higher. But how much higher? So again, there was a large TB-ESC study that was published a year or two ago, and some of you may have been involved in that. And in that, the ratio of TB disease, incident rate ratio, was 1.57 if you were QFT positive compared to TST 10 plus. And in other studies, it's actually less and ranges. So in a systematic review with, I think, 3 studies in that review, it was around 1.3 to 1.4. So risk is higher if you're QFT positive compared to TST positive. But it is nothing like the gradient of risk for HIV or close contacts or even recent immigrants compared to the general population. So again, it's the clinical risk factor that really drives risk and not whether it's a IGRA or TST. Okay, so graphically, again, using these kind of studies, what we see is that if you're IGRA positive, indeed, that's the black on the left. If you're IGRA positive, your risk of developing disease is higher than if your TST is 10 or your TST is 5. And then the difference between TST 5 and 10, as you know, is all about specificity. And of course, the more that you mix in people who don't actually have TB infection because of non-specific results or false positive results, naturally the risk of disease overall goes down. But again, look at the general population. So even an IGRA positive person from the general population has a lower risk than a recent immigrant with a TST of 5. So that's again the point. What drives risk is not the test, it's the risk factor. Okay, so another very common question is when you have discordant tests. So, and certainly we do this in here in Montreal. Someone is referred with a positive TST, and generally it's a low risk, what they used to call a low risk reactor. So healthy, normal X-ray, no history of contact, no medical illnesses, just like a healthcare worker who's starting work or even a health professional student. So in those groups already at low risk, many people do an IGRA. And if the IGRA is positive and TST is positive, is the risk higher? If the IGRA is negative, is the risk lower, and how much lower? So again, Jonathan Campbell kindly re-reviewed this recently. So this is based on a review he had done in 2020 and published. So 6 studies were identified, all in contacts. The population, at least majority, were tested but not treated and followed. And they had actually dual testing, sometimes sequential, sometimes dual from the outset. So what's in bold are the key numbers. And again, based on these 6 cohorts, which, okay, it's not, every study in the world, because it's relatively few that have done 2 tests and then followed people. So what's the relative risk? So compared to someone who's a TST is positive, no IGRA done, the incident rate ratio is about half if the TST is positive and the IGRA is negative, and it's a little more than double if the IGRA is positive in that same person who's TST positive. So by doing an IGRA, you do get more information. On one hand, you're double the risk, on the other hand, you're half the risk. It's a little less common that studies are done where people are TST negative and then get an IGRA, because clinically often, at least in our setting, it's usually the other way around. But nevertheless, there are a few studies and a few numbers, and the incidence rate ratio is about 0.65. So again, if you're IGRA positive and TST negative, your risk is a bit lower than if you're just an IGRA positive, all comers. These are not in the current version, but will be added. Right now, the current version is a bit difficult sometimes when you have 2 tests. And again, 2 examples that are drawn from here in Montreal. So a nursing student born in Canada, TST is 13. Basically, kind of very typical for a nursing student, comes in, really absolutely no risk factors. Why on earth they have this, we don't know. Maybe came to Canada, 10 years ago as a child, but risk of TB disease is low, very low. And if you do the IGRA and it's negative, the risk is now half. So it's really low. Half of very low is, yeah. On the other hand, take a 50-year-old nurse born in Canada, TST the same size, works in the emergency room, had a TST negative a year ago, and probable exposure 2 months ago. So now the TST is a conversion. There is some possible occupational exposure, sometimes always a little murky in the emergency room, whether you're exposed or not. Has diabetes, mild renal impairment, no symptoms. Again, chest x-ray is normal. So now what? Now I would say the risk of TB disease based on this is much higher. And if you do an IGRA and it's positive, okay, then it's even higher. But even if it's negative, I think I would still be debating treating or not. So that again is not currently in as much detail in the calculator, but is coming. Okay, so methods for the new website. So just to say, so that's all the back end, all the calculations. And then the actual front end, we did qualitative study with patients and providers, mostly interviews. So 15 patients, 15 healthcare providers. We asked them what they liked and didn't like. We actually produced a bunch of models or mock-ups and got them to give some input. And this is where we got to. So I'm going to stop for a moment and switch, hopefully quickly. Okay, so let's take, okay, we'll leave it at age of 40. It's always difficult when I ask people out of the blue what their age is, so I'll just leave it at 40. So the TST, let's say, is 10 millimeters instead of that. And for now, the IGRA is not done, and they have no risk factors. And you see, mostly they're fine because, as I showed you in the slides, the vast majority will not develop TB disease despite the positive test. About a small number will, and some of them will develop more severe problems. But now let's turn that person into a close contact. And so now the risk of TB is much more. And now perhaps you're interested to give some treatment. So let's give the patient 4 months of rifampin. So now what happens is you see the pink has turned to green. That means it's been prevented. So some of these colors and smiley faces, for those of you who perhaps liked just numbers, the numbers are over here on the right. And the smiley faces are, if you think it's helpful for patients, you can turn the screen and show it to them. And the yellow is adverse events. Admittedly, there's more than just hepatitis with 4R, but anyway, we've summarized all the adverse events in yellow. Green is prevented, and then pink and red didn't work. But this is for the healthcare provider. If you are considering what will happen if you take, so this is kind of accounting for the possibility that someone won't complete treatment. But the patient, of course, says, but doc, I'm going to take treatment. So if you click on the patient, it changes slightly. I'll just show you where, again, because the patients want to know if they take it, what'll happen. Of course, you could argue that the adverse events perhaps are slightly more probable, but for sure, what's more probable is that the efficacy is better because people are taking it. So now you say, okay, if you take it, your chances of developing TB are quite low, but you still have some adverse events. And then if you take a different treatment, so again, what happens with most of the different treatments is the number of adverse events changes. And down here on the right, there's a summary, which you can actually download. Okay, so that's the website as it is now. As I said, the one complicating thing that we have yet to solve is in here. If you have an IGRA and it's positive, generally speaking, your risk is higher, as I showed you before. Risk of disease and therefore benefit. I go back to no treatment. So if it's IGRA positive, not done. And what we haven't done yet is put in the more complicated calculations when you have 2 tests that are done. Right now, if you're IGRA positive, it doesn't consider the TST, to be honest. So it just changes. So you'll see if you're IGRA positive, you see the risk of TB disease goes up quite a bit compared to TST. Okay, so I'm going to stop there. I don't know if there's any questions now.
There's a couple if you'd like them now, Dick. That's up to you.
Yeah, let's go ahead. But Lisa, can you read them? Because
yeah, let me do the honors here. One question from Sergio is how best to keep track of which new chemoimmunotherapy or monoclonal antibodies pose an appreciable risk in TBI deactivation. So in this calculations, which which agents have you taken into consideration, and what would you advise to folks as they are dealing with whatever the latest and greatest?
Yeah, so that's quite that's a very difficult area because we first of all we really have just considered TNF alpha inhibitors, so the infliximab whatever, and steroids, and we have not. And again, we're limited mostly by the amount of information that's available, and we didn't want to take just small case series or case studies in some cases to try and estimate risk. So for steroids and TNF alpha inhibitors, there's enough data to kind of have a good sense of the risk. But for these other agents, yes, I agree. It's very difficult. I rely as much as anyone else does on things like UpToDate. I look it up and see, the mechanism, and then what do people think might be the risk. And but yeah, I know it's a complex area. As a default, for sure, I will usually consider if I don't know and I can't find anybody who knows, and there's not enough data yet, I usually consider them the same as TNF alpha. So I opt to be conservative in terms of offering treatment rather than not.
So, Dick, I haven't taken a close look at the FAQ information that you have, but I imagine this is kind of a common question. Do you address this in the FAQ with a simple explanation like you just shared?
So I'm not sure either, but we are in the midst of updating the FAQ so I can make sure.
All right, all right.
It is a difficult area.
And just a question I have, and there's more in the chat, but when you talk about the general population here, is this really derived for a North American population?
So, sure.
Right?
So that's actually a very good question. So in fact, the three studies were all done in high income countries. I know one of them off the top of my head was Bob Horsburgh was the senior author, and I can't remember where it was, but it was in the US.
Okay.
So yes, so they are all low incidence countries, low incidence, high income, whatever. But off the top of my head, other than one in the US, I'm not sure where the other two were. But they are all three are more recent. So the old calculator was based on a study from, I think, Denmark, large cohort study, and also Comstock study, both of which came up with an estimate of around 1 per 1,000 per year. But the newer studies, interestingly, much more recent, the risk is lower, more like 3 per 10,000. So almost 1/3 of the prior risk from older studies. And I assume that that's because a little bit maybe just false positive tests are just more likely as the prevalence of true infection goes down and down and down, even for IGRAs. And then the other problem is that, there probably was, in the 60s, still some community level exposure. There was probably still some reinfection going on, and that is even less likely now.
All right.
So all that to say, general population risk is lower than the earlier version.
Right. So just for everyone listening, this is a tool built for those of us here in low incidence, high resource settings based on the studies done. Victoria asks a question, do you think the positive IGRA is higher because positive TST can also be due to non-TB mycobacteria, and the TST will be positive if you had an NTM, let's say? So do you think that's really the driving force?
Yes, I think the difference in risk of disease with a positive IGRA compared to risk of positive TST of 10 millimeters is driven entirely by the difference in specificity. Yes, and obviously it matters what the population is, but these relative risk type studies are again largely done. I mean, the TBESC study obviously is done in the US, or US and Canada. I can't remember whether some sites are in Canada, but so very relevant kind of results. And that was, a relative risk of 1.57. Other studies where it's a bit lower, again, mostly done in high income, low incidence, low TB incidence settings.
All right. So different than a lot of clinical trials. This tool is actually built for our population. Rita is asking, just confirming this, you did say this is not validated for pediatric patients. What's your cutoff? Is it 15 or 18 years old here?
So, I mean, again, the data we've used are largely cohort studies and so on in adults. And whatever, I mean, sometimes the definition varies a bit, but generally I'd say 18. We've had a fair amount of discussion before we did all this. And we've had discussions since then with a number of pediatricians. Obviously, it would be nice. The part of the calculation with kids, of course, is quite, we get these very different risks depending on the age. And then the risk of adverse events as well, obviously, is quite a bit lower in general. So, and part of this risk calculator is, trying to balance the risks of adverse events with the benefits of treatment.
Yeah. So I'm going to get to one more. There are more. So if you let me know how many
Okay,
of
one
these
more and then
questions
we
you
can
can take.
switch back. Sure.
Yeah, and then we'll hold the rest till the very end. But Chris Spitters is stating, I was surprised how little impact on estimated future TB risk that presence of fibronodular opacities on chest X-ray had in the calculator. Prior dogma was nearly 1 log increase in risk. So I'm guessing that this is more the data you derived this from. Was there
Yes.
something new of recent or?
Yeah, sorry, I'm just going to get rid of that. Yeah. So it's not as much of a risk. And so to be honest, I'd have to go back and check exactly what studies we used for this. But in part, we're looking at studies that had absolute risk, so not relative risk. So some of the older studies that looked at relative risk, we didn't include them.
So
But
that
beyond
may
that,
be
I
the
can go
major
back.
difference.
And yeah, it's a significantly less, and granulomas also less.
All right.
So
And
that's put us more closer to previous. So we do have, maybe not yet, the references. Again, partly, of course, we're trying to get the modeling study, which has all the references and enormous supplements published. And that'll obviously be helpful to get some of these
yeah,
details out in the open.
you do have a significant audience that does dive into your details. So I think they'll love it when your publication comes out. But Phyllis and the rest of you, will try to get to your questions at the end. And Dick, I'll let you keep going. Thank you.
Okay, so coming soon, as I said, Discord results, update the FAQs. Thank you. Suggestions, most welcome. Questions, I'll take it down. And a French version, perhaps less relevant for you.
Dick, with this actually addresses immediately the question that's in there. So the discordant test results, will it then allow you to input that your IGRA was negative?
Yes.
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 So Phyllis, that's your question.
Yeah. Yes, that was something we discovered on day 2 after we posted it. Yeah.
Always like that. All right, keep going. Sorry.
Okay. So why do we need a calculator? So really, at the end of the day, after all this work, a year's work, blah, 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 webinars, talks, etc., I was kind of reflecting, like, why on earth do we need a calculator? Does everybody have calculators? So apart from the fact that I need a calculator for almost everything these days, why do we all need a calculator for TB preventive therapy? So think of this scenario. So you have a sore throat and fever, you feel bad, you're worried. Not any ordinary sore throat. You go to a walk-in clinic. After waiting NN hours, which is highly variable, I recognize in different settings, the physician sees you, looks at your throat, says, now you're really worried. The doctor says there is a 10% chance this could be strep throat. I chose 10% for a reason, obviously. That is serious enough. You should take antibiotics. You're a little skeptical. You ask, how long do I take it? Will it work? Doctor says, good questions. The treatment lasts a month. It's 90% effective if you take every dose. You then ask, is it safe? You'll need to come back after 2 weeks for a checkup. You'll have some blood tests. We want to make sure there's no side effects with the treatment. So now imagine how worried you are with that scenario. So what's wrong? So first of all, obviously what's wrong is the diagnosis. We only have 10% certainty that you'll develop TB, and that's an average. And really, many people have much lower probability of TB disease. So the diagnostic test is obviously a problem, even for IGRAs. The treatment duration. So many infectious diseases now involve a single dose, whether it's parenteral or PO. And those are the ones that are really successful treatments. But for TB prevention, frankly, 1 month sounds great, right? You all thought 1 month was a bit foolish, a bit short. The safety. So again, the safety, and I'll show some slides next. with most antibiotics, you're talking about serious adverse events 3 to 10 per 100,000 treatment courses. For TB prevention, we're happy with 3 to 25 per 1,000, which works out to 100 times more frequent. So 3 per 1,000 is the rate of hepatotoxicity with 3-HP or RIF, 4R, and that is 100 times more than the standard antibiotics. The monitoring. Ask yourself, have you ever taken antibiotics and you had to come in for blood tests halfway through? You had to have a checkup, someone had to call you, and yet for TB prevention with our current treatments, it's normal. So to get rid of calculators, obviously we need a better test. Okay, to be honest, I'm not working on a better test, so I'm going to skip that. We need efficacy, we need effective treatment, we need it to be safe, very safe. We need it to be short, of course, 2 weeks, single shot, 1 dose. Monitoring, we need something that does not require monitoring. During treatment, no baseline labs, just give it, take it, go away. So, talking about hepatotoxicity. So these are slides courtesy of Bill Berman and from an older review. So amoxiclav, hepatotoxicity, and then you see some other antibiotics, including 2 that we don't recognize the names, and that's because they were withdrawn because of these rates of hepatotoxicity. Now, ask yourself, what's the rate of hepatotoxicity for rifampin, PZA, INH? Well, it's here. So rifampin, which I usually say is the safe one, is still like way more toxic than all the other regular antibiotics. INH is obviously much worse, pyrazinamide even worse, but still, they're all orders of magnitude worse. So, just turning back now to what we have. Again, a systematic review done here. And bottom line, what we saw was with 4R, 0.6% severe AE, 2.9% drug discontinued, 28 cohorts, 11,000 people, 3-HP, 37 cohorts, 16,000 people, 1 death, 3.6% severe AE, 0.2% drug discontinuation. Again, that latter is particularly related to the drug, that sort of hypersensitivity syndrome, and 6 to 9 INH. Again, we're all very familiar with that. And a network meta-analysis we did and published a little over a year ago. Bottom line, 3-HP completion, of course, is better, but treatment-related adverse events with drug discontinued was worse with 3-HP. Bottom line, at the moment, 4R is the safest, but as I showed you before, 4R is far from ideal. Okay, so again, moving on quickly, future options. So here's some things I'm going to touch on, like 1 slide each. I'm not actually going to mention 6-levo because it's for MDR contacts, although it was a great study. So first of all, food. So I couldn't resist, kind of felt I had to bring up food. It's been tested in a randomized trial, cluster randomized trial, massive trial, 24,000 household contacts, 50 to 60% reduction in the incidence of TB disease in the following 2 years. Very similar, certainly as good as 6-INH in terms of overall reduction. Needless to say, no adverse effects, very safe, required no monitoring for adverse events, and also, needless to say, many other benefits. So it's been recommended. Of course, the caveat is that the setting where it worked was a setting where the majority of household contacts were malnourished at baseline. Their BMIs were less than 18. But it does, again, I think it's just an important reminder that food or social determinants in general are important. Okay. I think everyone's familiar with 1-HP, and perhaps people on the call may be more familiar than I with the current status of many studies. So this is just a reminder, 3,000 HIV infected, 9H and 1-HP were daily and self-administered. completion rates were excellent with both, but better with 1 HP. TB rates, 1 HP was non-inferior. Adverse events, they reported adverse events throughout the follow-up period, so the adverse event rates are very high and very similar, although the rate of drugs discontinued was only around 2%. But 1 HP was not substantially better than 9H, sorry. Again, sort of more studies are ongoing. So it's conditionally recommended. Several studies are ongoing. Again, I've not seen published, but I know some have been presented. Clinicaltrials.gov lists several as completed. So I'm sure more evidence on safety, tolerability, and efficacy is coming soon. TSTin4D, so we looked at this and published on this last year. Double dose RIF has been looked at in a mouse model here at McGill with very good results in the mouse model. In the human trial, it was no difference in terms of grade 3 to 4 adverse events or stopping medication for adverse events, but there were some problems with completion, so we're not quite clear on tolerability. Anyway, it's 2 months instead of 4, so it might be some advance, but there are others in the wings. So current trials, so we have 6 weeks daily rifapentine and others. I'll just show that. So this is the TBTC trial that, again, some of you are involved in. There's mouse model data that 6 weeks daily rifapentine alone should be adequate. It's ongoing. It's a large trial, 3,400 is the planned enrollment, and 1,120 is the enrollment as of last week. So, but expected completion is still quite a few years away. 1 month bedaquiline. So this is a study, I believe, that is back on, is what I understand. 1 month of bedaquiline. For contacts and others. I think what I hear is that it's going to be mainly in South Africa, and a kind of phased approach, safety and tolerability will be assessed first. Bedaquiline seems to be safe, but the main use has been in multi-drug resistant TB, and it's obviously quite difficult to be certain of safety in that population when it's given with so many other toxic drugs. So obviously a trial where it's given alone, that'll really help us understand the safety and tolerability. Finally, Starlet. So this is a study that I'm leading. So this is shorter and safer treatment regimens for latent TB. We had to throw a few extra letters in there to get Starlet, but the main point is shorter and safer. So this is a phase 2 where we're assessing safety, tolerability, completion, acceptability, etc. at 8 Canadian sites, 4 international sites. It's an adaptive trial, so we're starting with 2R20 and 1 LP. We're substituting levo for the INH in the hope of reduced liver toxicity. Again, most model data suggests it's exactly the same as 1 HP. And it's an adaptive trial, so we will introduce at least one other regimen as we go. Current enrollment, I'm pleased to say, is exactly 1. We enrolled our first patient last Friday. And conclusions. So individual risk factors drive TB progression and other TB-related outcomes, mortality, disability. TPD, so all regimens modeled reduce TB disease and post-TB disability, as well as TB mortality, and all regimens improve qualities. 4R and 3HP have higher benefits, both because of, again, even though they have side effects, the side effects tend to be less likely to result in hospitalization or death, and better adherence or completion. And older groups have surprisingly high gains or benefits. But again, I'm underlining that in low-risk populations, there is little benefit. It's not zero, but it's pretty small. Positive IGRA is associated with higher risk of progression. Again, largely related to the specificity that's improved. Again, in high-risk groups, the TB incidence is high with any test, and in low-risk groups, the risk is low with any test. So, current TPT of 3 to 4 months, good efficacy, reasonable safety. New TPT is obviously all the studies are working to shorter and shorter. I actually was talking with Lisa before we started. Again, I'm kind of concerned that an obsession over duration has blinded us a little bit to the need for safety. And I think that safety is key in any new regimen because it will eliminate, first of all, calculators. Who cares? If it's perfectly safe, you'll just give it. But more importantly, it'll eliminate the need for follow-up, for testing, baseline testing. You won't need any of that. And if it's 1 month or less, would also allow one visit, only one visit to basically, and then come back as needed. There are several promising regimens, but again, more work is needed, although it's ongoing. I'd like to acknowledge a lot of people that helped with the TSTin4D, but particularly Mayara Bastos for a great deal of work, easily 1 year of her life, and for sharing slides to Bill Berman and Jonathan. Okay, stop there. And in fact, I'll stop sharing.
Dick, thank you. Wonderful. And there are a few questions in the queue, and I'm sure there's more to come. But Sergio, I know this is another question for you, and if you'd like to unmute, but you have a question about, will the older TSTin3D be retired? I ask because inputting similar data gives quite different risk results, I notice, to the point where now many of my patients have a really low risk of reactivating, lifelong risk in the absence of immunosuppressants, using the 4D model, whereas in 3D, 4D model it might be less than 1 to 2%, and then older model, it was 4 to 5%. So the difference between the two versions, if you're using better updated data, I guess I'd say, why keep the old version?
So sure.
But, I'll let you answer, Dick.
Sure. So no, we do plan to retire. We had actually left the other one up partly in case the 4D one crashed or whatever, and also just as a transition, but we do plan to, as you say, retire it, move it, and go with the 4D. I mean, in general, most, I'm not quite sure what specific group would have gone from 45%, but certainly low risk reactors. The previous calculator might have given you a risk of 3 or 4%, and now we're looking at often a risk of 1% or less. And that again is largely driven by the general population estimates that we were, there were just much more modern estimates of general population risk with positive tests. And so we use those instead of the older from the 60s population-based estimates. And
I see you have your hands up.
I just wanted to clarify. I did actually mean 4 to 5%, not 45%. Sorry if that didn't come across in the question. So thank you for that. I see primarily two groups of people. The one that are going to get the immunosuppressants, those ones are easier to deal with. I ask because the other very, very large cohort of patients I see in my dedicated clinic are the new Canadians in Brampton. And I notice a big change from the 3D to the 4D where their risk really now with this better algorithm or better data, it's quite low indeed. And so it's changed. It's very important because it's a big change in practice for a lot of us, because whereas before 4, 5, 6%, you'd be more inclined to offer it. Less than 2% or less than 2.5%, not so much. And so that can really affect practice. So thank you for clarifying that.
Yeah, but and I'm surprised like you are on the data in older population greater than 65. In the past, Dick, the life expectancy calculations were only up to age 80. Many of our clinic population folks, at least in the US clinics, like in San Francisco, are pretty old. They're in their 70s, 80s. We even have many cases in our 90s. And people wonder, a person who's fairly fit in their 80s, their risk of having adverse effects are going to be different. Their risk of disability, things that would matter to them if their life expectancy is another 10, 15 years, it would be significant. And I'm wondering, do your calculations still cut off at 80? Was that what was in the...
No, so we've eliminated at least the upper end of the limit.
Okay.
Although, I'm not sure we have, like, you can enter the age of 99. I haven't actually tried that, but perhaps it's there. But certainly there's no upper limit. I mean, obviously where the uncertainty comes is, when you go over the age of 75 or 80, you start to have very, very limited data. Almost no randomized, nobody's in a randomized trial in that age, and very few cohorts report, adverse events at that age. I mean, no one's getting treated, right. So there's not much experience. So quite a bit of uncertainty as to the likelihood of adverse events in that age, above 75 or above 80. That's the only caution I would say. So we've projected benefits, but really most of that data comes from people who are 65 to 75, because that's where the majority of safety data comes from.
All right, I'm going to turn to Frank Irvine's question. Is there not some information that the risk of disease continues past 4 to 5 years from immigration in patients coming from high-risk countries of origin?
So in the model, so you're right. I mean, of course, 10 years out, there is still some risk. It kind of declines slowly back down to sort of baseline. But 5 years is kind of traditionally what most people consider the period of highest risk. And again, it's also where the cohort studies, drew a cutoff point. Some cohort studies, they said a recent immigrant is anyone up to 5 years. Some said up to 2 years, and then they followed those people over time. So our limitation is always that we're drawing from published studies. So we don't, if someone says a recent immigrant we defined as within 5 years, we have to accept that that's the definition we use. I hope that's clear. It is the limitation of, we're building a model on using published data as much as we can to get the estimates of risk. But there are some limits to how granular that is.
Right. Yeah. And again, I think that plays into where the FAQs are often helpful for you. If you really end up using this in your clinic on a routine basis, I'd read through what they have. And certainly we can share these chat questions with you, Dick, if folks are looking to see what common questions are. So Jana, you're writing here, I'm quite new in the TBI treatment world. Are there any sources that would help to guide risk-benefit threshold for treatment similar to like we use with lipids and cardiovascular disease? For example, with these recommendations, would be given if your risk is less than 7%, statins aren't worth the benefit. So, what risk is, when do you start treating? I guess.
Yeah. I mean, a little bit.
It's a shared decision.
Yeah. A little bit, right. It does vary. I mean, part of the idea of the smiley faces was that if you show it to somebody and, they see there's rather few benefits and there's a lot of that yellow stuff, I showed it even at our own, team to one of the persons working for us is more like an admin person. So not medically, au courant. And So she was like, whoa, that kind of impressed by the yellow was bigger than the green, right? So
yeah.
I know that's pretty simplistic, but nevertheless, that's sort of the idea of the visual representation. There isn't an absolute cutoff. I mean, we found that because current treatments are, reasonably safe, and TB disease, obviously a bad disease, there was no cutoff where you could say, okay, now it's harmful to give treatment. Like with INH, used to be, you'd go on the negative side because of the adverse events. Less so now, but the gains in terms of, a low risk, a healthy person taking 4R or 3-HP, the gains are very small. So it's much more like a real trade-off for them. And so it's the personal decision of, am I very concerned about TB and I want to prevent it and I'll put up with the treatment, or, this is just an inconvenience and I want to get on with my studies or whatever.
Hope that helps, Gianna. Because I know we can talk about that for a long time in individual cases. Stephen Wong brings up something that I think other people have said. I have the same question. Did the 4D version remove the variable of BCG status? I don't see that anymore. And I guess the question would be why? Or is this all something that will, when you get the IGRA negative and you really take into account both tests being done and getting discordant results,
yes,
will that factor back in?
Yes. So almost all the studies were of contacts, the majority of the population would have had BCG. So often in infancy and so on. But again, the studies of discordant, so all those relative risks I was showing you are from contacts. And in those, the majority, I mean, I'm sure it's true in San Francisco, but in Montreal, the majority of our contacts are foreign born, just as our index cases are foreign born. So majority of them have had BCG. So indeed, the cohort studies kind of account for BCG because the overall risk was in people who've had BCG vaccine, right? Now, how many had BCG, we didn't specifically look at it, but the cohorts included people with BCG. So inherently, that is why, IGRAs look better. They wouldn't look much better if there wasn't a reason for false positive TST in there.
Yeah. I don't know if I'd say the majority of contacts, because anymore, a lot of the households are mixed generation. So the younger folks would be US born, and many of the older relatives then would be BCG vaccinated. So there may be more of a mixed population in household contacts. But still, so when you add more ability to analyze discordance, that may or may not be something that you can check. All right. Stephen adds, any data on risk of TB disease with discordant IGRAs, one QFT positive, but another QFT a week later negative. So it's okay to ask questions, Stephen, always. So that's a question.
Yeah. So that's a very difficult. So first of all, no, we don't account for that in the calculator. It's kind of based on one test and not these problematic discordant IGRAs.
Serial testing,
which is usually, again, what I read is that it's usually when you've got one that's kind of borderline weekly positive, and then you repeat, and then you see it negative a week later, usually.
Mm-hmm.
And there is some literature that those are, less likely true positive, but I don't think we have good prospective data on those kind of people. There's just not enough of them.
Yeah, that would be true. It's and then you'd have to factor in different tests serially, the ability to boost, and there's just not going to. I doubt that there's any data on larger populations.
Anyway, the studies we've done in IGRA,
nice on a wish list, Stephen, because it is our reality. People get tested in different places, and they'll flip and they'll flop, but be hard to put into an analysis. Fiona Thompson asks, does the risk of adverse effects with each regimen increase with the chronicity of disease? That is young and healthy versus advanced age with multiple comorbidities.
So, so in general, so for INH, we're all aware of the strong age relationship. And so for 3HR, obviously, as well. For 3HP, I believe there's an age relationship as well. For 4R, at least our analyses, not a strong age relationship. So in other words, not as much, not a trend as increasing adverse events as you got older. But that's like one study and, kind of goes against the usual biology. So the majority of studies anyway, basically show an age relationship. That older people are more likely to have adverse events than younger people in general. And yes, people with comorbidities are more likely than people without. It's a bit noisy when you look from study to study, but that's a fairly general overall trend.
And that's the beauty of your calculator, isn't it? Is that kind of that general clinical sense that you might have, that here are the folks that would do worse. You're weighing that in your head, but your calculator allows you to put it in and it weighs it and calculates it based on the best study data that you have.
Yeah.
So that really is, that's bingo, exactly what your calculator is helping with. So hope that helps. Rita, you're bringing up food, which I'm so happy you included that, because it is a no-brainer that we wish we could write the prescription for food as readily as we can write for any other thing that helps, but we can't often hear. Food for TPT raises concern in my mind about how many people are taking the GLP-1 drugs for obesity now, and whether that confers some degree of malnourishment that could raise the risk of TB disease in those who have untreated LTI. I've never thought about this. Are they malnourished if you're reducing your food intake? And obviously, good question, Rita. We're all shrugging our shoulders here. Anybody who has any idea here, or there are, I'm sure, folks here who may know more, please do chime in, because there are a lot of people who are giving your thumbs up to that question, like they're wondering. Bernice asks, regarding the levoquin question, risk of C. diff. I guess you'll be calculating adverse effects as you substitute levoquin into, maybe that trial that you're doing. Do you expect to see adverse effects with C. diff?
Yeah. So it's interesting though, the Vequin trial, they didn't report C. diff. They did study the microbiome, and of course it changed, but even diarrhea was not a common problem, and this was a placebo-controlled trial, and not a major reason for discontinuation of therapy. And that was 6 months of levo. So, partly we went with with levo because the Vequin trial was levo for 6 months in like 1,000 or something MDR contacts in Vietnam. So a large study, and well tolerated. Yeah, we're a bit past time.
I know. I'm seeing those now. I'm scrolling down. I'm so sorry, folks, because I know that there are a lot more questions here. Dick, we might be able to, send a few your way.
Okay, yeah. Send me the chat or the questions or whatever. That would be helpful anyway for our. I'll try to answer some. Yeah, good.
Dick Menzies, he's always around. He's there to help you. We'll get out some FAQs, but we really fabulous to have you, Dick, sharing your wisdom. And thank you, everyone, for joining.
Pleasure. Thanks for inviting me. Okay. Bye, everybody.
All right. Bye-bye.